Copur index. Pediatric patients have a significant anatomical and physiological differences in their airway compared to the adult. Here, there is a Colorado Pediatric Airway Score, which is Copur. C for chin, O for opening, P for previous intubation difficulties, U for uvula, and R for range of motion of the neck. So coming to chin, from a side view, it is given to a score of 1 to 4. Like if it is normal, score of 1 like that. So it can be either normal or a small and moderately hypoplastic, or a markedly recessive chin or extremely hypoplastic chin. Then coming to the mouth opening, which is interdental space in between the front teeth. Here also there is a score of 1 to 4 with the more than 40 mm, 20 to 40 mm, 10 to 20 mm, and less than 20 mm. Then coming to previous intubations without difficulty or OS histories. Here also score of 1 to 4. Intubations without difficulty, no past intubations or OSA evidence. Previous difficult intubations or OSA symptoms. Then score of 4 gets can't lie supine or difficult intubation anticipated, or unsuccessful or emergency tracheostomy needed. Coming to uvula, here the tip of uvula is visible, uvula partially visible, or uvula concealed, and soft palate is visible. For the score of 4, the soft palate is not visible at all. It is range of neck motion. Here, observe the line from ear to orbit, and we need to estimate the range of movement by looking up and down. This like we need to measure the degree, more than 120 degrees, 60 to 120 degrees, 30 to 60, and less than 30 degrees. Some modifiers, like we need to add point for if it is a prominent buck tooth or macroglossia or extreme obese, or a case of mucopolysaccharidosis. So prediction points and few difficulty, intubation difficulty, and glottic use. So score of 5 to 7, there will be easy intubations only. Score of 8 to 10, it will be a little bit more difficult. So it needs a laryngeal pressures, and we could get a glottic view of 2. With a prediction point of 12, we could get a difficult intubation. So it's better to go for a fiber optic, which will be less traumatic. Score of 14, we get a difficult intubation and extremely needs a fiber optic, since we will have a glottic view of 3 here. Score of 16 is extremely dangerous airway. We need to consider either awake FOB or advanced methods, or we need to go for a tracheostomy. If we get a score of 16 plus, which is incompatible with life without an artificial airway. Few syndromes like we can go for like Down syndrome, Peary-Robinson, Treacher-Collins, Beckwith-Friedman, and Kippel-Feil syndromes, Eppert syndromes. These are few syndromes where we could apply this index and assess the airway difficulties.
Okay, very good. So this is Copur, nothing but an acronym of factors which you take into consideration for assessing a pediatric airway. So this was once upon a time asked in a short note question. So just share the slide for that. So Copur, it is a Copur index assessing the scores are given for chin. First C stands for chin, O stands for opening of the mouth, E stands for previous intubation, and U stands for uvula, and R stands for range of motion. So these are the things that we have to take into consideration. So the chin movement is considered all given 4 points each. Okay, 1, 2, 3, 4. Normal is 1. Small hypoplastic mandible is 2. Very markedly recessive mandible is 3. And extremely hypoplastic is considered 4. So more or less these are relative terms. So the variation will be there. Subjective variation is likely to be there, but it is a rough guide for you to be prepared to assess that you may have difficulty in the pre-anesthetic evaluation itself, so that you are not caught unaware of a situation where you cannot ventilate or you cannot intubate the situation. So this is the picture shown to see how the mandible is almost going like a straight line instead of having the normal curvature. And mandible should always come in front of the maxilla. That should be the normal disposition. So when the mandible is receding and it's behind the maxilla, all these cases, whether it is a child or adult, you will have to be very watchful. And mouth opening, you can, of course, in very small infants, it cannot be done unless you forcefully open their mouth. But in other cases, you can ask them to open the mouth and find out the gap. If it is more than 4 centimeters, it is considered as a normal or one. Then if it is less than 1 centimeter or 10 millimeter, it is considered as an extreme degree of restricted mouth opening. And similarly, patient who had a previous intubation attempt or who has a history of OSA, this is that history to be taken into consideration. So previous attempt, if they have done a easy intubation and a child comes for repeated surgical procedure, you give a mark of 1. But if there is a note, nowadays, people are quite aware of the difficult airway situation, unlike the earlier days when they used to not examine the patients properly and then on the table land up with a difficulty in visualizing the glottis and intubating. So nowadays, everybody has been repeatedly made to become sensitive about the difficulty in intubation and the airway difficulties. So all workshops and the PMEs, everything, we have topics being discussed on that. So if there has been a difficulty in intubation in the earlier surgery, nowadays they give even a medic bracelet to those patients to say that they had difficulty in intubation, how they managed that, and what were the side effects or complications that happened. So the trial is given or a note is given, and in extremely difficult cases, they give what is called a medic bracelet, where they will say this patient had an extremely difficult airway to manage. So that will caution you to think of other alternatives, like as you said, awake fiber optic intubation or even a tracheostomy may be life-saving rather than trying to induce and trying to intubate the patient. So the uvula with the mouth opening and the tongue being put out, you can see here it's a small baby. They are trying to visualize the uvula by forcefully opening the mouth. Or you make the child cry for the purpose of watching the or looking at the uvula. That is the only way that you can do. Some older children, because of separation or stranger anxiety, they will cry and open their mouth automatically. At the time, you can have a view of the uvula. And this is something like your Malambati story, where you can see the uvula, you get grade 1. If you can't see the uvula, you get to grade 4. Same thing, only soft palate is used. So this is something like the component of your Malambati. And the range of neck movement, this is also taken into consideration. And these are, once you have done this, so all the things are given up to 4 points. But getting a higher mark in this examination makes you a more difficult patient. So lesser the marks, you get a good patient. Higher the marks, you get a very bad patient. So 5 to 7 easy intubation, and 8 to 10 you may require laryngeal pressure. 12 more difficult or fiber optic that may be useful. 14, 16, all these things are all increasingly difficult conditions. So being 5 components, you can get up to a maximum of 20 marks in the most difficult cases. But in 20, most of the patients are not practically possible. So majority of them will not be there in the doing conditions. So we take a maximum of 16 as a dangerous airway considered awake intubation or potential tracheostomy to be thought of. Okay, so this is one of the rarely asked short note question which you have to remember. So remember the 5 components: chin, opening of the mouth, previous intubation or OSA history, uvula visibility, range of motion of the movement of the neck. Okay, these components you have to do. Right.
Yes.
Okay.
Uh,